Good morning, everyone. Welcome to this track 3. We will be here for the morning. My name is Moritz Spangemacher.
My name is Laura Kärtner.
We're both psychotherapists in the episode study, and we are very glad to present the next talkers here. I'm very excited to present Matthias Liechti, who's going to do the first talk today. He's a professor in clinical pharmacology and internal medicine at the University of Basel. With his research group at the Department of Biomedicine, he investigates the pharmacology of psychoactive absence, both in vitro and in human. Actually, you probably all know him because if you ever wrote an application or something like a manuscript for a psychedelic study in humans, you have probably quoted him. I'm very excited for his talk. Thank you very much.
Thank you. It's a pleasure to be here. These are the disclosures, and we'll dive right in because we have a tight schedule. So as you know, the subjective experience, the acute subjective experience induced by these substances may be relevant for the outcome in patients, besides from it being an impressive experience, of course. And just a few examples. The older one, that the mystical experience ratings are correlated with the depression or anxiety outcome, as shown by Roland's group. Another example from the first depression trial done by Robin Carhart-Harris and team. Here we have another scale, the 5D-ASC, and you can see that the positive scales or subscales, experience of unity, spiritual experience, blissful state, insightfulness, as discussed yesterday. These are the positive scales contained in the oceanic boundlessness dimension, and they all predict a positive antidepressant outcome. So patients who have high acute effects on these ratings weeks later will have a more positive response in terms of reduced depression. On the other hand, if you just induce anxiety acutely with your substance, here it was psilocybin, this will not predict a good outcome. Actually, in this specific data set, it was even predicting a worse outcome. So that means you don't really want to induce just anxiety, maybe a few of these more difficult experiences, that's unclear. So it's not all just fun, of course, as you know, but we generally want to have positive acute effects which then predict a good outcome. Here from another study in Basel, patients with anxiety disorder and a treatment with 2 doses of LSD. And during the first session, these oceanic boundlessness scores were assessed. And you can again see more positive ratings, meaning oceanic boundlessness on the 5 dimension of altered states score predicts a more positive outcome 16 weeks after this session. So 4 months later, there is lower anxiety with these positive effects correlated, but not any negative experiences were not correlated. But on the other hand, if we look at the mystical experiences in the MEC30, that was the scale that is used typically in the US, we see the same connection or the same association as with the 5D-ASC. And oceanic boundlessness and mystical experiences, it's pretty much very similar or almost the same. So there's a high intercorrelation. The scores in healthy subjects after LSD are essentially correlated at 0.9 or something. So it's very similar concepts. This is a novel study done in 60 patients with depression. They got a low dose, blue, of 25 micrograms of LSD, which corresponds to 5 milligrams of psilocybin. And they got either 100 or 200 micrograms of LSD, the red dots. And in both groups, so low dose or high dose, in both groups there was again this correlation between the acute effects and the longer term reduction in depression. Here, there was no placebo group in this study, and also from the fact that we see this correlation, we conclude that the low dose was kind of also active. That was also what was observed, actually. They had an acute effect, so it's not really a placebo, rather it's a low dose versus high dose comparison. It also means that the study was very well blinded, because the patients essentially all had an experience, and typically they were not able to tell whether this was a high or a low dose. But the higher dose had a significantly higher reduction in depression compared to the low dose. So it was actually more effective than the low dose. But the low dose was possibly also effective. We don't know, because there was no inert placebo. But why am I telling this? The subjective experience, the acute effects seem to matter, especially if they're more positive. You want to have a more positive experience. This is not to say that this experience then somehow is necessary for the outcome, as described in one of the slides yesterday. It's just saying that this is kind of a biomarker which can predict the positive outcome. It may be that it's critical and necessary, but we don't really know. It could also be that the subjective experience is just an epiphenomenon, but it at least predicts the outcome. So, but for us, we still believe that it partly is mediating the long-term experience. So it's so rich in terms of what you experience acutely with these substances that we believe that there is some therapeutic aspect to it. So we think these insights matter, and the beautiful state that you're in matters somehow. And this is also the reason that we believe that we can run phase 1 studies in healthy subjects and optimize the acute response and find the right dose to induce such a response, and then kind of use this data and information also for patients. So this is the other example that we conducted in Basel, where we treated healthy subjects with an antidepressant or a placebo before psilocybin. And the concept here was that we wanted to find out whether patients later on who get psilocybin need to stop their SSRI before they get the psilocybin. This is an important therapeutic question. And in our hands, with the healthy subjects, a pretreatment with escitalopram did not alter good drug effects of psilocybin. So the pretreatment was for 2 weeks and in healthy subjects, so not for months and not patients. And we also noted that the bad drug effects were significantly reduced, as was fear. So if we go on the other scale, the more specific psychedelic scale, you can see the OB ratings that are very predictive of the outcome. They are the same whether you have an antidepressant on board or not. However, anxious ego dissolution and anxiety is significantly reduced. So if anything, the SSRI had benefits, right? You would actually want to have it. And certainly not stop it and induce withdrawal syndromes, and then you are even more irritated and in a bad state before you give the psilocybin. So based on this data, we would actually keep on the antidepressant. There is no increase in body temperature above what we already have with placebo. So we always see a slight increase in body temperature if we give a psychedelic or MDMA, but it's the same if you have a pretreatment with a serotonergic substance such as escitalopram. And as you know, this has now been confirmed by the Compass group. 19 patients where they kept the SSRI treated with psilocybin responded to the psilocybin. There is no placebo group, so it's not a controlled study, but at least they saw a nice reduction in the depression and concluded that this seems to be possible. So currently in the Swiss program, where we treat about 500 patients right now with either psilocybin, LSD, or MDMA outside of studies, so this is already some type of limited medical use, we do not stop the SSRIs. The antidepressants go on. Okay, dosing recommendations that are derived from the data that I showed you for psilocybin. Typically, we would start with maybe 20 to 25 milligrams, 25 being the dose mostly used in the clinical studies. Some studies have already used 40 milligrams, for example, in patients with alcohol use disorder. So this would be a high dose, and it's typically used not in the first session, but maybe in a later session. 20 milligrams of psilocybin corresponds to 100 micrograms of LSD. We don't adjust for women or men or body weight, so we give the same doses to everybody. And within the dose and weight range that is currently has been used in studies so far, so not including very obese or very slim persons, there is no correlation of the body weight and any effects or plasma concentrations. This is not to say that there is no correlation at all, but not within a, let's say, more normal range. Probably no need to pause the SSRI. I would stop antipsychotics, trazodone and mirtazapine, because they antagonize they block the 5-HT2A receptor. And yeah, there's a few more information. Some of it is derived from experiences in the program rather than from clinical studies. So let's switch to LSD. How does LSD and psilocybin compare? We currently have 2 studies that looked at this in the same subjects. Here were 30 subjects treated with either 2 doses of LSD or 2 doses of psilocybin. And we had no equivalent dose in this study. This was the first comparison, and we did not, essentially by chance, we missed the right corresponding dose, because the 200 micrograms of LSD is stronger than 30 milligrams of psilocybin, as you can see. So the right equivalent dose would have been 40 milligrams of psilocybin equals 200 LSD, and 20 psilocybin equals 100 of LSD. And you can essentially see that the blue lines just last longer. So LSD lasts longer than psilocybin, otherwise it was pretty much the same. And this is the second study, also including a little bit more than 30 patients, no subjects, healthy subjects. They all got LSD or psilocybin, and now you can see that the 100 micrograms equivalents to 20 milligrams of psilocybin. So if you read a study on LSD or psilocybin, then you can use this factor to see what the equivalent dose of the other would be. Mescaline has also been included here, and 500 milligrams of mescaline would be equal to these other doses. But it's currently not used therapeutically in studies. Rather probably outside of studies. Okay, this is the dose equivalence. If we block the 5-HT2A receptor, we do see a reduced response. This is the black curve here. These healthy subjects had different doses of LSD, up to 200, and the highest dose, 200 micrograms of LSD, together with ketanserin, which was given before the session, and you can see that this then drops to maybe an equivalent of 25 milligrams. So they have a slight effect, but it's almost gone. 5-HT2A receptor blocker, that would be an antipsychotic. So if you have an antipsychotic on board, if at all, you would probably want to stop this before you treat your patients with one of these substances. Otherwise, the experience will be reduced. There's no danger. It's not a dangerous drug interaction, but you would probably not get the full response that you get without these medications on board. There's another observation. If we increase the LSD dose from 100 to 200, the positive drug effect, so from here to here, the positive drug effect is not further increasing, meaning that maybe we have already reached a plateau. Maybe not in each individual, maybe not in each type of disease, but in healthy subjects, we can see some kind of a plateau. We haven't tested 150, so maybe the 150 would still be higher, but the 200 micrograms not higher than 100. However, you see here for ego dissolution, we go further up. So for this very specific type of experience with a psychedelic ego dissolution, a higher dose will produce more ego dissolution, but not more positive drug effects. And since the positive effects mostly correlate with the outcome, maybe 100 micrograms is already enough for LSD in a therapeutic study, maybe. We actually don't have such data for psilocybin. So sometimes people say psilocybin is better researched than LSD. Historically, that's not true. It's not even true probably for some of those findings. I'm not aware of any study using psilocybin in whatever, healthy subjects or patients, really assessing the different doses. We don't know. Has to be done. Pharmacogenetics. We have no pharmacogenetics on psilocybin. We don't know whether if you are a poor metabolizer of some of another enzyme, whether the concentrations are increased. It's the case for LSD, and I'm just showing you this as an example. So genetics play a role typically in the PK, meaning that the concentration of the psychedelic may be higher or lower. So in this case, we just looked at all our subjects, what their metabolism type is, and among these 81, we had 7 poor metabolizers and 74 normal metabolizers for this specific enzyme. This is one of the common enzymes breaking down CNS medications. And as you can see, the guys with the poor function, so they essentially cannot metabolize medications via this enzyme, they need to do it via others. You can see that the LSD concentration is slightly higher, and especially the effect is lasting quite longer, so a few hours longer. And so this was a pharmacogenetic approach. We essentially looked at the subjects, what's their genetics, and how does this influence the response. And then we did a study where we kind of treated the subjects, healthy subjects, with a 2D6 blocker, MDMA. It is a psychoactive substance as well, but it's also a blocker of 2D6. So we should see the same thing. Now the enzyme is blocked pharmacologically, not genetically. So everybody will now be kind of a poor metabolizer. And again, the concentration of LSD was slightly higher, and it lasted longer to get rid of the LSD. So the half-life was 5 hours compared to maybe 4 hours. So essentially, if you have a medication, the same would probably be true if you're pre-treated with paroxetine or any other 2D6 blocker. Many antidepressants are, or as I mentioned, if you're a poor metabolizer, genetically, this is about 7% of the population in Europe, then you would have a longer LSD response. Essentially, in these patients, you could lower the dose of LSD potentially by 20%. And with MDMA, also, not only the PK was affected, so not only the concentration of the LSD, but also the effects were longer. So the effect duration was roughly 10 hours in the combination, and only 8, a little bit more than 8 hours if they got LSD alone. And this is not the psychoactive effect of the MDMA, it's the fact that it blocks the breakdown of the LSD. The psychoactive response of the MDMA there is also a slight response of the MDMA, which, when put on top of the LSD, doesn't matter. So MDMA is just kind of too weak to really dramatically influence what your experience with LSD. It's not changing anything. Well, this could be discussed, but we think it doesn't change a thing. And it's also gone after 6 hours, right? So, yeah, it's a pharmacokinetic interaction. So LSD dosing will probably start with 100, starting dose 100, high dose would be then 200, no body weight adjustment, same dose in women and men, maybe reduce the dose in 2D6 poor metabolizers, pause antagonists, and we don't know about pausing the SSRI. So in terms of times, I will shortly show you a few more information on MDMA, maybe 3-4 minutes, and then we go into the discussion. That's fine? Yeah, captains? Yeah, good. Okay, key thing with regards to the pharmacology, I'm a clinical pharmacologist, I'm not a psychiatrist, so we're talking about pharmacology here. LSD is in the blood for a long time, and the effects last exactly the same. So simply put, when it's in the blood, when it's in the body, there is an effect. And this can be shown with such a hysteresis curve. So up is effect, x-axis is concentration, and it goes up and down along essentially the same line. Now, MDMA is very different. MDMA has a long half-life. It's staying in the body for 1 or 2 days. But the effects last 6 hours. So how can that be, right? You have essentially after 2 hours, you are on the top of the concentration. And the concentration stays high up to 3 hours, 4 hours, and then it goes down. But the effects are going down despite the high concentrations being maintained, right? It's completely different from the psychedelics. That's important. So, for example, it's important for the argumentation, why do we boost? Why do we give another dose of MDMA? Why does Rick give another dose of MDMA after 2 hours? They're dosing with 120 and another 60. Well, here they're giving more MDMA, but the concentration, even if you give nothing, will stay high for another 3 hours, for another 2 hours. And the effects are going down. You can do whatever you want. You can increase the neurotoxicity, but I'm not sure whether you can increase the effects. We don't know. There is no study. And the protocol for the phase 3 studies, the 2 phase 3 studies with MDMA, used this booster design. But nobody did the other thing that essentially would be considered safer. Maybe you don't need another half dose. Yeah, we will know in hopefully a few months when the comparison study in healthy subjects at least is completed. Genetics matter, again, similar to LSD. You get a faster increase in drug liking and in blood pressure in the first 2 hours in poor metabolizers of 2D6. After that, it's essentially the same because MDMA itself, as I noted, is an inhibitor of 2D6. But it takes 2 hours to inhibit the enzyme. So when you start taking MDMA and you're not a poor metabolizer, the effects are actually initially higher, and it takes some time until you then get this phenomenon of kind of mimicking the poor metabolizer genotype with MDMA. And then for 2 weeks, you're a poor metabolizer because your enzymes don't work anymore. Final slides before we go to the discussion. If you give an antidepressant, a serotonin inhibitor or norepinephrine inhibitor, mostly serotonin inhibitor, before the MDMA, the response is reduced. So that is why you typically would pause the SSRI. It's not dangerous. So if somebody doesn't want to stop because of fear of withdrawal syndrome, you don't have to, but expect the subjective MDMA response to be lower. And with MDMA, I would say the subjective state that you experience acutely probably matters for the therapeutic outcome. I have no evidence of neuroregeneration and neuroplasticity for MDMA. Maybe somebody has, but I haven't seen it. So we cannot argue it doesn't matter what you experience. It probably does. Okay, the rest of the slides is in the handout. It's essentially a summary, and there's also this table kind of compiling all the interaction data that we already have. You should have it in the handout, the online handout, and it's used in the Swiss therapy program to kind of make decisions what to stop and what to keep on in the patients. It's not final, only part of it is scientifically kind of supported, and the rest is maybe from anecdotes or experience. So, thank you very much. We'll switch to questions right now.
Thank you so much. I'm always amazed how many good data do you have. It's really nice to see.
Not mine, it's the team.
Yeah. Do you have, I see a question already right there.
Yeah, we don't know much. If we stop it, there is a fear of relapse into the depressions, typically used to enhance the antidepressants and to reduce the suicidality, the lithium. So typically we don't treat patients with bipolar disorder or just like mania, so it's rather patients where it's given for suicidality. But we have observed and some cases with possible seizures, or there is a fear of this. I think there may also be some publications on this. Probably we would have to study it, kind of, but it's not so easy to study because inducing seizures, and it may need a large, we just don't know. Mostly we keep it on, but not, for example, if somebody has a history of seizure, we will probably not keep it on. Yeah. Mostly we keep it on right now and observe what's going to happen. But this is the interaction that we actually fear a little bit.
David has a question.
Thank you. Yeah, I also want to thank you for the incredibly important and solid pharmacology work that you guys are doing. In terms of the SSRI and psychedelic interaction story, these 500 patients that are treated in Switzerland that you are somewhat following as well, do you have any knowledge from the therapists or even collecting proper data on what they do clinically, practically, with the, if people are on SSRIs, to find out?
Yeah,
what
they
is the
keep it
practice?
on. They keep it on right now. So essentially, we advise them to keep it on, and this is now since 1 year, I'd say. But I cannot say that we have not even anamnestic data to support whether this helps. It's too early. So we have to do it maybe for 1 or 2 years. But currently, they typically would not stop the SSRI in these patients. For psilocybin and LSD, but for MDMA, they do.
Yeah, but isn't there a practice or history of therapists thinking, oh, let's then give a little bit of a higher dose if people are on SSRIs? Is that then disappearing, or is that just a myth? Do you know whether
they even increase?
Yeah,
or?
they actually.
No,
I thought
we
they
don't
gave
increase.
higher, and people took higher doses if they were on SSRIs. But that's they're
So
just.
I would say we don't pause anymore.
Okay.
Maybe 2 years ago we paused the SSRIs in these, so that the program is now going on for like 9 years or something, and it's increasing. And we could potentially even check a little bit how this turns out, but so far it's also another anecdote. Yeah, we are actually doing a study with LSD and the 6-week treatment of paroxetine before. So we'll have the interaction also for LSD, but it's still in healthy subjects. But 6 weeks of pre-treatment instead of just 2.
Okay, we have time for one last short question.
There's some old data with mice and rats that suggest that LSD has a secondary phase that is dopamine receptor mediated. Is there any data in humans that suggest that?
There's no human data supporting any difference between LSD and psilocybin in controlled studies. So in our studies, now in 60 healthy subjects, there's no difference whatsoever, besides from the longer duration of the LSD. And we don't see something like a dopamine phase. And another evidence for this, that it's not existing in humans, is the fact that if we give ketanserin, we block everything. So mice must be very different from humans.
Okay.
Okay, thank you so much.